All right, good morning, everyone. I hope everyone had a great Thanksgiving or however you celebrate or don't celebrate it. And I hope your travels were okay. So we have two talks as usual this morning. The first talk is Frostbite, a Societal Disease by Dr. Fred Endorf, who's an associate professor in the Geitz division, focused on burn and critical care. He's a native of Minnesota, did his undergraduate at Syracuse University, not too far from actually where I'm headed, medical school at Mount Sinai, and then did general surgery at Loyola, and then a burn and critical care fellowship at Harborview Medical Center. So you were all over the country. He's got many publications, over 50 publications focused on burn and critical care. I noticed that wherever you are, whichever city you're working, you're voted best doctor, and congratulations on that. And we were very lucky to recruit him in 2024 to our burn service, which is really one of the jewels of the Department of Surgery. And I've really seen our burn service evolve over the past 14 years under Dr. Wichter's leadership, and keep going. And we look forward to your talk, Dr. Endorf. Thank you.
Thank you, Dr. Schulich, for that nice introduction. Thanks to everyone for being here this morning. We're going to talk about frostbite this morning. Want to identify some risk factors for frostbite, understand how some societal factors influence outcomes in frostbite, and then learn about some potential interventions to hopefully reduce the incidence of frostbite in the future. I entitled this the societal disease. I realize it kind of sounds like social disease, which has a different connotation altogether, but really going to talk about some societal and environmental factors that play into frostbite. There are a number of other diseases that are kind of influenced by society and the environment. Multiple things play into a patient's health behavior, social, economic environment, clinical care, the physical environment, which is probably more influential in frostbite than a lot of other disease processes. Asthma is a classic one. Individuals that live in racially segregated metro areas are more likely to be exposed to air pollutants. Even patients of color that are in non-metro areas are disproportionately more likely to be living near polluting industries. And then some racialized zoning, property laws, redlining, that may actually limit their choices of where to live and increase their risk. All of this kind of leads to patients using acute care, asthma care more commonly than other patients. Carries over to things that we do. Gallbladders, non-white patients they have less access in general to preventative care, so they're more likely to present for emergent cholecystectomy rather than getting their gallbladder out electively. TBI, Hispanic and Black patients are more likely to get, are less likely to get intensive rehab after their injury. That's even independent of their insurance status. And then insurance alone can actually contribute to overall survival. So patients with both non-small cell lung cancer and breast cancer have been shown to have decreased survival if they have worse insurance. So frostbite is influenced by a lot of these things. Those diseases that I mentioned earlier, asthma, cholecystitis, TBI, lung, breast cancer, those also widely occur in patients that are not clearly affected by those factors. Unlike those, severe frostbite is almost entirely caused and or influenced by these potentially modifiable societal factors. This is kind of the unholy trinity of frostbite: homelessness, substance abuse, and mental illness. All these things kind of have an interplay that make patients at higher risk for frostbite and worsen their outcomes. Up until pretty recently, frostbite was not well studied in this country at all. In Finland, which is obviously a colder climate, one study showed about a 10% lifetime incidence of severe frostbite. Back in 2018, we tried to look at this and see what the true incidence was in this country, looking at the National Burn Repository and National Trauma Data Bank. And at that time, it was really poorly populated. We found only about 500 patients over a 10-year period with frostbite in the NBR and about 400 in the National Trauma Data Bank. For context, I was at Hennepin County at that time. We were admitting about 50 to 60, sometimes up to 100 frostbite patients a year just in that institution alone. So kind of very, very poorly populated databases. The new burn care quality project was just kind of the updated burn database. They are including frostbite, so it's probably time for an update of this study. But at that time, just to underscore kind of what this disease does to people, 10% of those patients were getting an amputation of some kind. So very high morbidity. And then there was limited socioeconomic data in these databases at the time, but about 17% of those patients were uninsured. So we thought that the burn population might be a good comparison to see how these societal factors affected these patients. What we did is we were kind of concerned just on rounds anecdotally that these patients were more challenging from a social standpoint, getting them discharged, a lot of the mental health and substance abuse care. And so we compared frostbite patients to burn patients who just had isolated hand or foot burns, thought that would be a good control population. And we found that they indeed were more challenging. The hospital length of stay was double in frostbite patients with a similar size injury as burn patients, and about double the rate of needing ICU care, although they spent similar days in the ICU. As you'd expect, some medical factors such as being on the vent, needing surgery, those predicted increased length of stay, but non-white race also predicted an increased length of stay. And hospital costs were significantly higher, almost 3 times higher in frostbite patients compared to burn patients. Fewer of those patients were discharged home. Survival is high in both groups, just going to show frostbite's a disease of morbidity rather than mortality. Again, medical factors did increase or predict increased costs if you had frostbite, if you're on the vent, ICU, et cetera. Race and those other socioeconomic factors did not predict increased costs. So why did they have this increased length of stay and charges for frostbite? We presumed it was due to the prolonged stay, waiting for discharge to shelter. They have a higher barrier to TCU generally. You would think, well, of course, amputations versus skin grafts, that's going to lead to a longer length of stay, adjusting with therapy. Really, the standard of care generally is to have a delayed amputation for frostbite. And this study only looked at the primary admission. So subsequent admissions, including planned readmissions for amputation, were not included. So this probably underestimates the increased length of stay for frostbite, actually. This is a study just this month from Canada, also looking at the impact of housing on frostbite versus burns. This is from Edmonton. They looked at almost 600 thermal injuries, burn and frostbite, over a 30-month period. And this included 414 patients with housing and 157 unhoused patients. And what they found was frostbite accounted for about 35% of the admissions in the unhoused population, significantly higher than the 10% of housed patients that had frostbite. You might think that's 10% of people with housing had frostbite, but I just point out that Edmonton has about average January low of 6 degrees Fahrenheit versus 20 to 22 degrees for Denver. So significantly higher risk just from the environment alone up in Edmonton. Substance abuse in that unhoused population was significantly higher. And then I'll touch on this a little later too, but unhoused patients on the burn service were 10 times more likely to leave AMA. Really, really high risk. So we also noticed a high rate of readmission in these frostbite patients. And a lot of these were unplanned. We talked about the delayed surgery was a planned readmission, but we looked at the nationwide readmission database. Over 2 years, about 1,000 index hospitalizations for frostbite and 842 total readmissions. Some of these were multiple readmissions. And they had an estimated unplanned readmission rate of 35%. So just putting that in the context of some of the other surgeries we do in GITES, very, very high readmission rate. You'd expect some of the medical things that we found, but a little over half were associated with complications that you'd expect. Cellulitis, infection, necrosis of their stump, osteomyelitis, things like that. But there were also some other factors associated with that. Medicaid, much higher risk, 1.5 times the risk. Being homeless, 1.5 times the risk. If you signed out AMA, you were 3 times the risk of having an unplanned readmission. And for multiple unplanned readmissions, if you signed out AMA, almost 6 times the risk of having multiple unplanned readmissions. Medicare was also a risk for multiple unplanned readmissions. We kind of theorized that was due to the aged population, other associated medical problems unrelated to the frostbite. So just to sum up, drug or alcohol abuse, homelessness, Medicaid, and then just being discharged AMA, those were all independent predictors of unplanned readmission. And then if you signed out AMA, you had a higher risk of multiple readmissions. Anyone working in any field in a hospital, just not even just frostbite and burns, can recognize some of the traits that you see in patients that sign out AMA, and I would just say that's very prevalent in the frostbite population. So we wanted to look at, do these factors increase your risk of just getting frostbite in the first place? Looked at the national inpatient sample, compared patients with frostbite. This was over a 3-year period. It's about 7,600 patients with frostbite, and compared those again to burns with isolated hand or foot burns, which is about 35,000 patients. In that frostbite cohort, 68% had drug or alcohol use and or dependence, very high rate. And then 35.6% were homeless, really, really high rate. And 21% had a mental health diagnosis, and only 13.3% had private insurance, non-Medicare and non-Medicaid insurance. And frostbite injury in this study was associated with Medicaid insurance, homelessness, any mental health diagnosis, and drug or alcohol abuse. Also peripheral vascular disease, which intuitively makes sense. Poor peripheral perfusion in this injury is likely to make things worse. In this study, black race and homelessness were independently associated also with getting amputation in frostbite injury. So we want to look at whether those or some of these other socioeconomic factors predicted the risk of amputation as well. This was looking at social determinants and poor outcomes, which is we measured amputation and unplanned readmission. Again, used the national inpatient sample. In this one, we looked at frostbite patients only, but compared homeless versus non-homeless cohorts. And a total of 24.6% of the homeless patients got an amputation compared to 15.6% of the non-homeless patients. Again, these were primary admissions only. So if we had included the delayed admissions, guessing that rates were likely to be significantly higher. And then predictors of amputation, homelessness, black race, and then of course cellulitis. If you have an infected frostbite, much more likely to need amputation on that primary admission. Surprisingly, in this study, a mental health diagnosis predicted fewer amputations. And our theory on that was that maybe these patients had to be stabilized in inpatient psych, so a lower rate of them had their amputation on the primary admission and a higher rate on the subsequent admission. But we decided to look at a single institution study just to kind of get a more granular look at this, looking at biopsychosocial factors associated with complications in frostbite. This one was all adult frostbite patients over a 9-year period admitted to Hennepin County. We found that predictors of amputation in this study were history of drug and or alcohol use. Just any use was 1.4 times the risk. If you had a known substance use disorder, 6 times the risk of an amputation. Other psychiatric disorders trended towards predicting amputation, but did not reach significance. Similar for unplanned readmission, substance use disorder, 3 times the risk of an amputation. I'm sorry, of an unplanned readmission. If you're discharged to a homeless shelter, you had over 5 times the risk of having an unplanned readmission, which makes sense. You're not getting maybe the proper dressing care, the family support, something you would get in inpatient rehab, something like that. And then again, a psychiatric disorder predicted or trended towards predicting an unplanned readmission, but it was not significant. Why would you get a higher rate of amputation for homeless patients? Well, there's effectively one magic bullet treatment for frostbite, and that's thrombolytic therapy. We know that thrombolytic therapy in the first 12 to 24 hours drastically reduces the need for amputation as well as the level of amputation, how proximal the amputation is. Hennepin looked at this actually too at a really granular level. We get bone scans, triple phase bone scans to assess the tissue perfusion in frostbite. So what they did is they looked at people that got the initial bone scan and then another bone scan after thrombolytic therapy to see the response. If they've had full response, full restoration of tissue perfusion, the median time to getting their thrombolytics was 5.5 hours. If you went out to 7 hours for these partial responders, people that had a partial response, it was just a median of 7 hours. People that didn't respond to the thrombolytics was a median of 10 hours. So just a few hours can make a difference in the response to thrombolytic therapy. And that actually correlated well with surgical outcomes. The people that had a full response did not have amputations. And about 40% of the partial and non-responders had some level of amputation. This is just an illustration of the bone scan here. You can see lack of tissue perfusion here on the toes on the pre-thrombolytics. And then post-thrombolytics, full restoration of perfusion. This is a full responder. So homeless patients, they often, first of all, present after that window. They're just less likely to seek medical care, are often even found outside by other people after the effective window of thrombolytics. And then they also have multiple freeze-thaw cycles over several days or weeks. We'll have patients that sometimes come in, maybe they're in the initial therapeutic window, but they give you a story that they've been in and out, frozen, rethawed over the previous days or weeks. We know that thrombolytics are ineffective in that patient cohort, and so it's actually a contraindication for thrombolytics. And then mental illness and substance abuse just may cloud the recognition of frostbite. Very classic story for us that someone goes on an alcohol or drug bender, so to speak, and then someone finds them, even if they're housed, finds them past that 24-hour window. They don't even realize that they've been injured until everything washes out. So that's likely to be the higher amputation rate. So what can we do for these patients? Some community resources. Colorado Coalition for the Homeless, we work with them. They offer some housing resources, help navigating some of the housing applications. The state does have a temporary rental assistance grant, and they help apply with that. And then they have some resources to prevent evictions. So that's just looking to prevent homelessness at the root cause. Colorado itself passed a law in 22 that protects renters from discrimination, in part by establishing upper limits for security deposits, income requirements, just lowering the bar for affordable housing. Denver is spending about $50 million a year on homelessness initiatives, and still estimates that there's 40,000 units short of affordable housing. They had started off kind of using temporary hotel shelters. They're now shifting that strategy, looking into more moving people into permanent housing more quickly and support services. They did get about 7,000 people off the streets over 2 years, but at a high cost, obviously. Houston, not a frostbite climate necessarily, but they've been kind of held up as a model of homelessness initiatives in urban areas. They have a $70 million plan that they want to end street homelessness by 26, and that includes rapid rehousing, permanent supportive housing, mental health resources, a navigation center to help navigate all these resources, and then outreach to the communities themselves. Colorado Coalition for the Homeless also runs a medical clinic, Stout Street Health Center. They offer, among many other things, mental health care and substance use recovery for homeless patients. We also partner with them for post-frostbite admission patients to help with wound care, try and help prevent unplanned readmissions as well. They also have medical street teams, roving teams that go to some of these high concentration micro communities of the homeless to offer basic medical care. I gave a talk to them recently, and they were asking about, well, could we target some of these places with socks, shoes, mittens, gloves, things like that to help prevent frostbite from the start. Harborview, where I did my fellowship up in Seattle, they did some educational materials for homeless patients as well. They had actually 6 different education materials. They called it the EQUIP, Equity and Injury Prevention. This was burn and frostbite education. But they just literally passed out some of these, and it's hard to see here, but just kind of cold weather tips, recognizing different stages of frostbite, recognizing signs of hypothermia, ways to stay dry, important to stay dry to prevent frostbite. And then again, just cold weather tips, multiple layers, hand warmers, doubling up sleeping bags, putting multiple layers of cardboard, things like that on the ground that can help prevent hypothermia and frostbite. And then again, staying dry. Eventually, they're going to make this available for other people, hopefully us too, but get it out in the community through homeless organizations, public health officials, fire departments, community clinics, and then hopefully burn centers as well. Just like to make a plug for our own addiction medicine department too. A lot of what they do is helping us initiate medications for alcohol and opioid use disorder when patients are inpatient, and makes that transition to outpatients too. They help us manage withdrawal in the hospital, and then help with emergency commitments if we think the substance use disorder is actually a danger to the patient. And then help us manage complex pain in the setting of opioid use disorder. As you can imagine, these amputations are painful surgeries. A lot of you will see these patients before they have frostbite on other services. If we can get these patients plugged into addiction medicine, maybe that will help decrease the rate of frostbite down the road. So just to sum up, socioeconomic factors such as mental health diagnoses, substance use and abuse, and homelessness increase the risk of frostbite. And then patients with those risk factors who sustain frostbite have worse outcomes, including more amputations and a higher rate of readmission. Potential solutions are going to be multifactorial, but likely some combination of hospital-based, nonprofit organization, and governmental interventions. And this is me modeling bad frostbite prevention. I'll take any questions that people have.
I assume it's the ice crystals, right? That's dangerous.
Yeah, you get extracellular ice crystals, and those destroy the cells. And then when they destroy the endothelium of the blood vessels, that's when you get thrombosis. You know.
So one way of helping the thawing process is using anticoagulation, correct?
Yeah.
But there must be other techniques that can be used. For example, when I froze cells in the lab, I used DMSO. I mean, you can't put DMSO in a person; it's toxic. But
the next kind of frontier, we're going to be doing a study on epoprostenol, so helping with kind of vasodilation, free oxygen radical scavenging, things like that too. So in combination with, we're using it as with our standard of care. So we'll see if that helps too.
Cool.
Yeah, every service has challenging discharges, but the way you've described your patient population, I'm wondering how you deal with the patient who has ongoing wound care issues that normally might go to a subacute nursing facility, but if they're uninsured and unhoused, how do you end up partnering with these community organizations to maybe get temporary housing for someone so they can have ongoing wound care to try to get at that 35% readmission rate?
True temporary housing is really still hard to come by despite Denver's best efforts. The shelter system is what we rely mostly on, and some of those shelters have dressing change capabilities, others don't. One thing we've been looking at, another study that Dr. Richter has, is looking at long-term silver-based dressings versus daily wound care. We've been doing that in the hospital. If that's equivalent, then maybe we can prolong the dressing change time so that they can even come back to our clinic periodically, even if they don't have temporary or permanent housing.
And you've spoken about the increased length of stay relative to the burn population. Is that really the issue, is that you're turning this acute care bed in the hospital into a long-term bed because the consequence of a discharge when you might normally have been able to discharge someone with better resources, instead you're keeping them in the hospital, and that's the cause of the length of stay?
Yes, 100%. The other problem is Minnesota, for example, is constantly cold throughout the winter. And so we have kind of a slow accumulation of frostbite patients. Here, there's episodic big drops in temperature, but a higher homeless population. So there's a huge influx at a time. So we kind of overwhelm the shelter system during these periods. So even if they had available shelter beds, we might only be able to get 5, 6, 7, 8 patients to those available shelters, and then have a huge backlog.
And then what is unique about the recreational frostbite victim? Meaning someone's out climbing a mountain, gets stuck in a storm or something. How do you treat them differently than this population, or is the care exactly the same?
Care is pretty much exactly the same. It's thankfully more rare to have severe frostbite. Most of these patients, even if they get trapped out for a prolonged period, have appropriate winter gear. Some of them have, some survival techniques and things too. They're typically less severe with some exceptions. We had wrote a case report in Minnesota, a guy that was snowmobiling, hit something and had a concussion, was knocked unconscious for a while, and ended up with 4 limb amputation on ECMO and all that kind of stuff. So those things happen, but typically less severe. We do recommend, obviously, don't do your first big Colorado adventure when it's -10, wait for more favorable conditions. But
And with friends.
yes.
Any other questions? Well, thanks very much for.
Yeah, thanks. Yeah.
Okay, our next talk is abdominal aortic aneurysms in women, looking at some of the differences. And this will be given by Dr. Meg Smith, who did her undergraduate training at Wesleyan and then did a lot of stuff at the University of Michigan, right? General surgery training. She received a master's also there, then did her vascular fellowship, and then came to us in 2024. She is well off on an academic surgical career with already 26 peer-reviewed publications. I noticed you've won several society grants, which is great. And we welcome you to the podium, and thank you.
Good morning. So I'm going to talk today about essentially what kind of merges my clinical interest and research interests. And everyone always told me, pick the thing to research and study that makes you really mad. And so the disparate outcomes for women in abdominal aortic aneurysms is kind of what gets me riled up. And so I'm going to kind of walk you guys through the background, some of the evidence for it, and then kind of a bit of a call to action. So abdominal aortic aneurysms, just quick background. We think that in the US, there's about 200,000 diagnosed annually with an overall prevalence of around 5%, although both for men and women, the prevalence rates are kind of all over the place. The biggest modifiable risk factor that we know is smoking. And here's a study that did roughly 10,000 screenings on patients regardless of risk factor. You can see that for both men and women that smoke, pretty high prevalence of abdominal aortic aneurysms. Our treatment over the past 20, 25 years has really changed from all open operations to endovascular repairs. And one of the kind of landmark trials back in the early 2000s was our EVAR-1 trial, which showed a 30-day mortality benefit with EVAR 1.8 compared to a little over 4% for open AAAs. And I'd be remiss if I didn't say that there actually is no difference in long-term mortality when you follow these patients out. But this really kind of changed our field. And as I'll allude to later, that we've had numerous really big landmark papers and studies that are international, and they all include a really low percentage of women in these studies. But things like EVAR-1 have really changed our treatment paradigm. And so we've gone from all open to our initial EVAR, we now have fenestrated grafts, which can be custom made for patients who need visceral stenting or it goes up into the visceral plate. We have iliac branch devices that can treat iliac aneurysms. We now have an off-the-shelf TAMBI device, which can treat thoracos, and our PMEGs, which are essentially us modifying a graft on the back table specific to a patient's anatomy. And so if you ask over the last 20 years, well, have we had success in treatment? Most people would say yes. We've seen a almost 60% decrease in AAA-related mortality over the last 20 years. But almost all of this has been in men. So this is age-adjusted mortality rates. And granted, women are going to be lower because it's less prevalent, but we really don't see a big delta or improvement in our mortality for women. And so I'd say yes, for men, we've had a lot of success, but over the spectrum of AAA disease, everything from diagnosis to even long-term post-op mortality, we know that women do worse at literally every stage of this disease process. And so my goal today is to kind of demonstrate this problem and really the need for my argument, which is really intentional study of women with AAAs. And I'd argue that this is probably true for many specialties that see kind of disparities and that we really need intentional studies of these groups and not just more health services papers that have sub-analyses that comment on that there is a disparity, but we have to start figuring out why. So if we think as early as diagnosis, we see kind of a challenge, and that really gets to screening. So as I showed earlier in that one, in my opening slide, we see that for smokers, you can see on the left here is in this group of 10,000 people of all risk factors that were screened, the prevalence of a AAA, and never smokers on the left and smokers on the right, that clearly AAAs much more prevalent in both men and women. And in the early 2000s, the US Preventative Task Force came out with screening guidelines for AAAs and said that men aged 65 to 75 who have ever smoked should get a one-time screening aortic duplex. And women the same age, there's insufficient evidence for this. So not that it's not beneficial, but we just don't have any evidence to support it. And in the actual paper, it says specifically that although evidence shows that women who smoke are at increased risk of AAA, the evidence is insufficient that screening this population confers a net benefit. And ideally, appropriately powered RCTs among women would be able to answer these critical gaps in evidence. And not surprisingly, we still don't have those RCTs. Now, our Society for Vascular Surgery, our kind of local grant, does identify that this probably is beneficial. And so the SVS does recommend a screening ultrasound for both men and women. But the answer is most primary care providers are the ones that are doing this screening. They're not going to know the SVS Society recommendations or guidelines. And most insurance companies still won't cover a screening ultrasound for women, with the exclusion of if you have a strong family history. So even when we think way up before we're involved, there's a challenge in terms of diagnosis of this. And we're probably missing a lot of women who have AAAs that have these risk factors, and we're not screening. Kind of moving down that pipeline or of the spectrum is the surveillance period. So we know someone has a AAA and they're kind of not at size criteria to repair, and we're in our kind of annual surveillance schedules. And we know women, and there's so much data to go through, but I just kind of picked a few things at each of these time points. We know that women grow faster than men at smaller sizes. We know that they have increased mortality and AAA-related mortality at small sizes during this, and that their risk factors or cardiovascular risk factors are poorly controlled. So having a AAA is an independent risk factor for cardiovascular disease, and therefore we recommend, and the AHA recommends, that anyone with a AAA should have a systolic blood pressure less than 140, essentially be on a statin with also an LDL cholesterol goal, be on antiplatelet therapy, and have complete smoking cessation. There was a really great study out of the Netherlands that looked specifically at patients that were enrolled in some of these really big RCTs. And they did fancier modeling that I can understand, but they looked at the patients in these studies who are not compliant or on target for these factors, and were able to model what their risk reduction would be if they, in fact, were compliant on these targets. And so you can see here smoking cessation, both for men and women, for patients with AAAs. If they were to completely stop smoking, they'd have a really pretty dramatic risk reduction in their cardiovascular risk over 10 years. And when you start combining compliance with these targets, we see even larger scales. And so overall, they concluded that optimal cardiovascular risk management in AAA patients would result in an average 25% decrease in 10-year cardiovascular event risk. And the answer is we're not doing well with men or women on this, and we know that, and there's studies that look at this, but they are almost all men, either say men in the title or their entire study population is men. And we actually, despite not doing well with men, do much worse with women. So this is some unpublished data that is combining patients in more recent RCTs. And we can see here that women continue to smoke at higher rates than men. And when we look at kind of medications and comorbidity treatment, they are achieving LDL goals less often. They're being prescribed statins and antiplatelets less often. So not only are we not identifying patients, once we do, we're also not kind of doing the appropriate risk stratification for them. Most of us as surgeons then start to think about treatment, which is kind of why we went into vascular surgery or went into surgery in general. And this is an area, again, where our data has really failed us. So first of all, we have truly no idea what the right size to treat women is. We know that 5.5 is our guideline for men. We say that we should treat women when their aneurysm is greater than 5. There's really no data to support that other than women are smaller, so we treat them at smaller sizes. And so this kind of well-known fact is really not grounded in strong data. So not only do we not know when to repair them, we know that they have higher risks of rupture, their rupture outcomes are worse, and we see disparities in elective repair. So when we think of ruptures, we know women have approximately quadrupled risk of rupture, female sex being an independent predictor of that. Women that present with ruptured AAAs are offered repair less often, both open and endovascular repair. And the women that do go on to have repair for a ruptured AAA have both worse perioperative morbidity and mortality. We see that with patients that are treated endovascularly and open. Now, ruptures are really hard, right? Patients come in, they often have a lot of other problems going on. Their anatomy can be really challenging to determine what the best operative plan is. And truthfully, mortality, even after repair, is pretty low. But we see problems with our elective repairs as well. So women with AAAs are offered elective repair less often than men. And a study that really identified this was out of Europe, and they took 400 patients, 200 women, 200 men with a AAA, and they followed them for 7 years. And over those 7 years, 48% were untreated. When they did a deeper dive, they saw that of those 48%, 35 or 67 of the 400 were truly untreated, meaning they had, for men, a AAA that was greater or equal to 5.5 centimeters, women greater than 5. So they met size criteria, but still hadn't undergone repair. When they broke it down, we saw that 8% of men were truly untreated, and 25.5, so about 1 in 4 women whose aneurysm met size criteria for repair had not undergone repair. Now you could say, well, you just told me you didn't really know what the best size criteria for repair is, and so maybe we should look at it in a different view. And so they did a separate analysis where they said, okay, let's use 5.5 centimeter cutoff for everybody. And even when they did that, women, 16% were untreated. So 16% of these women had an aneurysm that was more than 0.5 centimeter above size criteria and still were not offered repair. And when they looked, there really weren't any big anatomical differences. So from an endovascular standpoint, there was no difference in our neck lengths for proximal ceiling zone. Women trended towards smaller access size, but no significant difference. Women were slightly older and they had higher rates of current smoking and dementia, but ultimately neither patient nor aneurysm factors were able to fully explain this result, suggesting that there just is likely some bias that is driving our kind of offering of treating these patients. But we do offer and treat many patients, but unfortunately worse outcomes for women don't stop there. It continues in the post-operative period as well. So this paper looks at the percent of EVARs over from 2000 to 2015, and it kind of breaks it up into these 3 ranges. And the bar graph here is the percent of aneurysms that were treated endovascularly. And not surprising, really we saw kind of a takeoff of endovascular repairs in the late 2000s, kind of early 2010s. When they compared then perioperative or 90-day mortality for patients across these periods, we saw that overall there was a significant improvement in perioperative or 90-day mortality. But interestingly, that almost all came from men. And so when we looked at women, although there was that trend of increasing endovascular repair, we didn't see any mortality difference over those 3 periods. Now, that stopped in 2015, and we've had a lot of more contemporary devices come out. I showed you we have TAMBs, we have IVEs, we have ZFENs. And so maybe it's just that our experience in the last 10 years has gotten a lot better. And this was more a reflection of kind of early experience and less advanced devices. And so a group in Boston that does a lot looking at aneurysm outcomes specifically looked at the repair of complex AAA. So those that are above the renals that involve the visceral plate, and looked at between 2014 and 2019 and merged Medicare claims data in our basket, kind of our national like equivalent of NISQIP, our VQI, with about 800 women, 2,000 men. And they looked at perioperative outcomes, kind of 30-day mortality as well as 5-year outcomes. And what we saw is that for men, open AAA in these patients, what mortality risk was 5.1, significantly less with a fenestrated EVAR. And for women, not only were the rates higher compared to men, but there was no mortality benefit in endovascular compared to women. They did a kind of follow-up study, because again, this was really looking at open versus endo and not comparing men and women. So they did a follow-up study where they just took fenestrated FEVARs, fenestrated endografts for men and women from 2014 up to 2021. And again, you can see higher 30-day mortality rates of 5.2% in women and 2.8% in men. Now, they did note that women were more often treated in a non-elective setting. So they were presenting with symptomatic or ruptured AAAs. And so kind of commonly, they recommended screening and earlier elective intervention as a way to try to adjust this, which we've already discussed have problems in and of themselves. And then finally, we think, okay, well, let's say we get people through the operation, we get them through their 30 or 90 day, right? We treated their aneurysm. So there's really shouldn't be any long-term difference. And unfortunately, we also see that that's not true. So this paper went back to that. This is going back to the one that compared kind of the early 2000s to the mid 2000 teens. And they follow these patients for out to 1, 4, and then 10 years for some of the groups. And you can start to see that there is a difference pretty early on in the excess mortality after this. So women, despite getting through that operation, right, have a higher excess mortality long-term. And you really see it fall out at 10 years. They were able to kind of do a deep dive and figure out the cause of some of this and the cause of death. We see that cardiovascular death is the major reason, both for men and women, of mortality after a successful aortic aneurysm repair, but that it's much higher for women. And if we circle all the way back to the beginning, we know that we're doing a worse job with women in treating their cardiovascular risk factors. So again, women with AAA, and there's at every step of this, there's a bunch of other time points I could talk about, but essentially from screening and diagnosis to long-term mortality, women do dramatically worse than men at really every step. And while some people in my specialty would be offended by this, I think it's fair to say that we're really failing women with AAAs. And granted, there's some data that shows that there's provider bias that's likely impacting this, but I think it's mostly that we just don't know the right thing to do. So all of our big landmark studies are very underrepresented, or women are incredibly underrepresented in them. And so we're taking this data and we're just applying it to women, and we're seeing that the results aren't the same, but we don't really know why. And we don't have anything to suggest that we should be treating women differently or how we should be treating them differently. Now, I'm not alone in this, and there is a big international randomized control trial that has started recruiting called the Warriors trial that is looking at aneurysm, kind of smaller size aneurysm repair, as small as 4 centimeters for women. Shipra Arya at Stanford is one of the PIs here for this. And so that will, I think, really elucidate that kind of question of what is the right size, or should we be treating women at a different size? And then I'm excited to say that I think we're going to be kind of on the forefront of that, and that we just recently have started a women's AAA clinic here. And so myself with one of my colleagues, Dr. Yi, have started this. As far as we know, it's the first women's AAA clinic in the country. It's a half day per month. And the answer is, I don't know what the right answer is for women. And I'm not going to be doing other than really focusing on those cardiovascular risks. I don't have an answer of how to treat them differently. So the goal is to still provide the standard of care that we do, but to try to develop a women with AAA registry and really deeply phenotype these patients. And that clinic then also serves as a platform for future interventions, and selfishly also will serve as a kind of a basis for my future planned career development award, which hopefully will include our CU's internal Birch K-12 award in the next year, and then transitioning to a K-08 or a K-23 after that. So thank you very much. I wanted to a few shout outs to my division for kind of supporting and the resources for getting to do this women's AAA. Dr. Yi, specifically, and Dr. Naylor, who kind of joined me in this efforts and really supported my kind of career development. Dr. Matsumura, who's at the VA, who's been my primary kind of mentor in supporting me in tackling this. And then I'd be remiss if I didn't acknowledge a few of my mentors from Michigan, both clinical and research, who have really kind of given me the foundation to start this. And then also the Ludeman Family Center, who's given me some pilot funding, and the accords for I'm in the SCORE fellowship. And so my Darcy is my primary mentor for SCORE, and is giving me a platform and kind of opportunities and access for continued pilot development in this area. Thank you.
So Dr. Smith, great talk. And, you know, I actually, during my training, did a bunch of open AAAs. I think I did about 100 in my training. And back then, if an aneurysm was 4.5 centimeters, it was fair game. So what's happened? I mean, it seems like the mortality and morbidity of doing a AAA repair has come way down with endovasc, but the size criteria have come up. So, you know, what's going on there? And then my second question is, you know, why are we still following size? I mean, aren't there better tests, elasticity, maybe growth rate over time? Aren't there better metrics to decide who's at risk and who's not? I mean, if somebody has a 5.5 centimeter aneurysm and they've had it for 20 years, you know, versus somebody who has a 4.5 centimeter aneurysm that's doubled in size in the last, you know, whatever, aren't those better measures?
Yeah, great question. So I think the first is, you know, there's been more and more data that's using that. Essentially, a lot of these studies used 5.5 as men. There's a lot of studies that show that kind of nationally, we treat a lot of unindicated aneurysms still. And so there's a, you know, I think it's about, I have to look back, about 20-30% of aneurysms you look are technically not indicated based on size. I think a little bit has been because we have endovascular options and because they become so much more advanced in us, not, you know, we can do visceral stents, that people are comfortable waiting a little bit longer because it's not that if we lose our proximal seal, we're going to run out of options. We have more advanced technology. And the answer to this, the second question is yes, and there should be, and we don't know. So we've yet to kind of be able to determine in any kind of objective way who's going to grow quickly, who's not going to grow quickly, and who's going to go rupture. There's a lot of basic science work looking at elastin, and are there ways that we can both identify it. There's a group in Pittsburgh that's doing a lot of, and actually an engineering group doing a lot of 3D modeling to see, can we see wall stress? And then as part of a group here with some collaborations in New Zealand and Europe, we're looking at DNA methylation, which is an epigenetic marker that has been related to aneurysm growth, to see if, yes, we know smoking's bad and former smoking, but can we start to kind of track and personalize a little bit on what we think people's growth rates would be? The answer is we don't know. And it's often that people don't grow linearly, especially that people that come in ruptured, they'll have been stable for many years. and then they come in with a rupture, and it's not something that we were able to track.
Yeah. And you know, if you looked at coronary artery disease, it's the exact same story, right? I mean, you know, the old thinking was, well, women don't get heart attacks, and that's so untrue, right? And the exact same thing is happening right here.
Yeah, I had a meeting last week with the head of the Ludeman Center, and she talked about the same thing, cardiovascular disease, and the same thing. We have these, you just say all the goals, right? Blood pressure goals, statin, like LDL goals, but they're all based off men, and we just apply them to women. We don't actually know if they're right. And I think this is true again across specialties, right? In pretty much every specialty, there are disparities that we see, and most of it is that we're applying data and applying solutions to that. And we see that disparity, but we don't actually know if that's the right treatment or not.
So I'm sure your statements at the SVS of saying we're failing women go over really well. So I'm going to ask an even more provocative question. You may have seen a paper that was published in JAMA Surgery recently that said that female patients have better outcomes from general surgical procedures if they're treated by a female surgeon. So has anybody looked at the sex of the surgeon in treating female patients with aneurysm disease?
Not that I'm aware of, and being provocative is not something that I steer away from, as my colleagues here will know. And I took it out of my slide, but that is part of the argument too for the women's aortic clinic, right? Is we have some really fantastic female vascular surgeons here, and so why not leverage kind of that we've seen better outcomes for female patients when treated by female physicians. I don't know. The answer to your question about change in outcomes is I don't know. And right now, one thing we're really limited on, and to be fair, this is really exciting work because there's so much to be done, but the lack of data is really challenging in this because most of our databases are only patients that have had surgical interventions. We don't really have a good way of tracking patients beforehand. And for instance, VQI, as far as I know, doesn't track anything about the gender, but certainly be something interesting to look at.
Well, in this morning's two presentations, I heard research ideas that are incredibly good projects for residents and fellows. Any other questions from the audience? All right, seeing no further questions, thanks for attending Grand Rounds and have a good week.